afternoon, everyone, and welcome on this very cold Monday afternoon. My name is Tanya Brady. I'm the Senior IPC Nurse in Public Health at Hertfordshire County Council. So the aim of today's webinar is very much to raise awareness around sepsis and to highlight the life-changing effect or impact that this can have on individuals' lives. Being knowledgeable and able to spot the signs of sepsis enables prompt treatment with improved outcome and ultimately saves lives. So it is my pleasure today to give a very warm welcome to our speakers. We've got Dr. Ron Daniels, who's the founder and CEO of UK Sepsis Trust and Senior Lecturer in Intensive Care Medicine, who will be giving us a bite-sized overview of sepsis. We're also joined by Caroline Coster, who is a sepsis survivor, who will be sharing her inspirational story with us today. So thank you both so much for taking the time out of your very busy schedules to join us and share your knowledge, expertise, and experience in this very important topic. And also thank you to HCPA for hosting this webinar today. If we have time at the end, I'm hoping we can answer some questions. So if you have any questions, if you'd like to just post them in the chat, then we can address them hopefully at the end. So with that, I'm going to now hand over to Dr. Ron Daniels.
Thanks so much, Tanya, and hi everyone, and thanks for the kind invitation. As described, I'm an intensive care doctor, and I founded the charity in the UK Sepsis Trust, some 12 years ago now, and it's been quite a journey, which I'm going to share with you to a degree. So I'm just going to pause whilst I share my screen, which hopefully should be popping up now. Can you see something very orange?
Yes,
wonderful.
We can, yeah.
So really, when we're talking about sepsis, often we focus on what's happening in the acute hospitals. And of course, that's not solely where the problem lies. And we like to consider sepsis as a full health systems issue, from infection, which in 80% of cases begins at home or in the place of care, through to recovery, because recovery from sepsis, like from many other critical conditions, is a long-term process, and rehabilitation is a long-term process. Now, just a reminder to people listening that there is an official definition of sepsis, and this is the lay definition. It's currently being revisited because it's now 10 years old. And it identifies sepsis as a life-threatening condition, of course, that arises when the body's response to infection causes organ damage. Now, there's a couple of really important points in this statement. Firstly, sepsis doesn't have to be a severe infection. You can develop sepsis as a consequence of a UTI, for example. You don't even have to have bacteria in the blood to have sepsis. It's the immune system going into overdrive, overreacting, and that's what causes the problems. And just in terms of context, a reminder that this overwhelming immune response to an infection is also what has led around 85% of people with COVID-19 who've died in the UK to have died of sepsis, viral sepsis, if you like. But also we've heard a lot about invasive group A strep in the news recently. Well, that's sepsis too. So this is an incredibly prevalent condition. And it's defined by organ damage. So to identify someone as having sepsis officially requires that we identify which of their body's organs isn't working very well. Now, this is Villa Park, the home of Aston Villa Football Club, and it was taken, obviously, BC before COVID because it was full. And at capacity, Villa Park holds around 43,000 people. And that gives us some interesting context, because breast cancer every year in the UK claims around 11,000 lives. And of course, it's right and proper we continue to improve outcomes from that condition. Bowel cancer claims rather more, 16,000 lives every year lost in the UK. And again, of course, we need to continue to make improvements in our care of that condition. But sepsis claims an estimated 48,000 lives across the UK every year, more than breast cancer and bowel cancer and prostate cancer, and indeed car crashes all put together. So it's a hugely common problem, but it's important to remember that sometimes these conditions coexist. And a good example would be somebody who's had chemotherapy for breast cancer, and they develop what's called neutropenic sepsis because their white blood cells are affected by the chemotherapy. But a really important thing, and this really applies to a lot of the people that you care and advocate for in your work, it highlights a point. 20 years ago, when I first started in intensive care. If somebody was being palliated for breast cancer with chemotherapy, we would not even dream of putting them on an intensive care unit. But now we will, and we'll do so quite commonly. And we'll do so, we might not put them on multi-organ support, we might not put them on a ventilator, for example, but we will admit them so that we can give them some drugs to support their blood pressure, so it gives time for the antibiotics to work. And the point I'm making that even for people with life-limiting or life-ending conditions, the very basics of sepsis intervention remain appropriate, because if they are being palliated for something, if they are within the final months of their lives, then doing the right thing might just give them some high-quality weeks or months with their families. There's a sort of urban myth that sepsis is only about very old and frail people, and I just want to illustrate that that is absolute nonsense. These are data from New York State, and as a reminder, that has a population of 20 million people, and this was a government-funded statewide research program. And what they found is that among adults developing sepsis in this year of 2018, almost half were working age. So nearly 50% were less than 69 years of age. So yes, it's more common in older people, but it definitely affects young people too. Similarly, in children, you might hear people say that sepsis only really affects very sick neonates, often premature children or children with very high morbidities. And again, that's not true. Again, data from New York State. Thankfully, sepsis is much less common in young children, but more than half of children affected by sepsis were over 6 years of age. So sepsis can affect any people at any time. It's more than about sepsis, though. This is about infection. We know that in countries like ours, in high-income countries, where tropical diseases aren't very prevalent, that 4 sources of infection give rise to 95% of episodes of sepsis, and they are pneumonia, urinary tract, intra-abdominal, and skin and soft tissue, bone and joint infections. So a couple of years ago, we decided to look at the English data, and we accessed the hospital episode statistics for 2017, and we took out the obvious codes for sepsis. Sorry, the obvious codes for infection in one of those sources. And the results astounded me and will probably astound you. In 1 year, in England, not the UK, we saw 1.7 million people whose admission to hospital was either caused by one of those infections or complicated by one of those infections. Now, I'm sharing this for 2 reasons, because firstly, the people that we and that you are caring for and advocate for, it doesn't matter whether they have sepsis or not. If they have one of these serious infections, they will, in all likelihood, need hospital assessment and in all likelihood need intravenous antibiotics. And the second point is exactly that. When we talk about antimicrobial resistance, what we're really talking about is a future, and it might not be that far away, where we can no longer treat infections like these, so that more of them will give rise to sepsis. Antimicrobial resistance is not caused so much by our inappropriate use of antibiotics. The burden is here. It's caused by our desire to stop 1.7 million people dying in our hospitals every year. And of course, it's more complex than that. Across the world, sepsis is enormous. This was a study that was done by the Institute for Health Metrics Evaluation, and it was published just before the pandemic hit the West. And you won't have heard of the IHME, but you've certainly heard of the WHO, and you've probably heard of the Global Burden of Disease Report. And it's this group that the WHO commissioned to write the Global Burden of Disease Report every year. So these are estimates, but they're estimates by the most academically credible group of estimators on the planet. And they said that around the world every year, sepsis affects 49 million people, claiming 11 million lives. And again, some context. That's more lives than cancer. It's more lives than ischemic heart disease. And just as a reminder, and look, I work in intensive care, many of you working in care facilities, we all know how horrid COVID has been. But COVID so far over the last 3 years has claimed 6.6 million lives. Sepsis claims 11 million lives every year. But we have to talk about antimicrobial resistance in the context of sepsis. Lord O'Neill wrote this report now a few years ago, and he said that if we don't act now, then by 2050, we'll see 10 million lives lost every year as a consequence of AMR. I think he was being optimistic, if I'm honest. Already, we're seeing close on 2 million lives lost every year as a consequence of AMR. But those people aren't dying of AMR, they're dying of untreatable infections. Now, it might not be by 2050, but if we don't do something as a matter of urgency, it will certainly be in our grandchildren's lifetimes. We will not have effective antimicrobials. And that's not going to be 10 million lives lost every year. It's going to mean we cannot save lives for people with sepsis. So that would mean an extra 38 million, taking the total to 49 million lives lost every year. And that would mean that the human population would change from a position of growth to one of decline. So when people talk about AMR as an existential crisis, they are really not exaggerating. And it's these quanta that have persuaded significant international interest in and around sepsis when it's placed in the same space as AMR, which it has to be. The G7 ministers now take this very seriously. A number of years ago, we presented a resolution to the World Health Organization, and once they accepted it, we wrote an opinion piece in one of the journals. We asked the former Chief Medical Officer, Sir Liam Donaldson, to write a forward, and he said, some very important clinical issues, some of them a matter of life and death, exist in this backwater inhabited by professionals and academics and enthusiasts. But the public and political space is where these things need to be in order for things to change. Now, I am going to come on in a moment to the clinical recognition of sepsis, but to start with, I want to tell you about an important function of a charity like ours. It's public awareness. Now, we're small. We don't have a marketing budget. There's only 14 employees, so we don't pay for any advertising space. Now, 8 of the 10 English ambulance services have livery that describes what sepsis looks like, trying to get the message out there. We work with large format advertising space in city centres. Again, it's donated to us for nothing. And we have a slightly softer message of just ask, could it be sepsis in those non-clinical spaces? And we work with sports clubs and we work with corporates, again, to get the message out there to their demographic and to their clientele. You won't see another story in Holby City like this one, but they were very good to us and had the posters for many, many months on their programme. But we work with other soap operas, and it just might be that we might see another storyline in a major soap opera within the next few months. We're working to get the message into schools with the Sepsis Savvy for Schools programme, and that's funded with the generosity of Iceland Foods, the frozen food people. And for any of you that have community groups or are involved in schools or run businesses, we have a free set of resources, Sepsis Savvy, that aims to educate your community, your workforce around the signs of sepsis. It's free of charge and it can simply be downloaded. So on to what you thought I was probably going to talk about, the clinical systems approach and what you can do to help recognise sepsis. There is an NHS England action plan on sepsis, and this is now in its 3rd iteration. So NHS England takes sepsis very seriously indeed. Now, across most facets of healthcare, the recommendation from NHS England, which we support, is to use News 2 as the starting point to screen for sepsis. But it hasn't penetrated everywhere. It's being used variably in GP surgeries, and it's being used variably in community-based services. So this might not be a resource that's applicable to everyone listening to this talk. But if you are using News 2, it's not perfect. It will change again over time. And eventually, I hope we'll have different versions for different age groups and comorbidities. But at the moment, it's the best tool we've got to help us to recognize deterioration in otherwise well people. So I'm going to start with the tool that we use in the acute sector, and I'm going to describe the tools that we use in the community. So in the acute sector, we start with a patient who looks unwell, which is really important. That clinical judgment, that gestalt, if you like, should trump any screening tool in any facet of life. So if you're worried about someone you're caring for, whatever the screening says, if, for example, their heart rate isn't quite hitting the mark, but if you're worried about them, you should feel empowered to act. News 2 is there as a redundancy, really. It's there to help you decide if you're not otherwise sure what to do. We then qualify it with, could this be an infection, or is this likely to be an infection? These tools that we have here, excuse me, are all endorsed by NICE, so they use NICE language. I probably would have put there, is this likely to be due to an infection? But NICE preferred, could it be? And we then, in the acute sector, start to look for a red flag. Now, these are not magic. These are based upon variables within the News 2 score, together with other stuff that we can measure easily at the bedside in the acute sector. Now, some of this other stuff won't be as applicable in areas where many of you are working, such as measuring lactate, for example. But you could easily find out whether someone's recently had chemo. You can easily ask someone when they last passed urine and so forth. And if you have basic physiological monitoring devices, if skills allow and training allows, then you can easily identify these red flags. And we use these to empower people to act. And in hospitals, we ask people to then start a package of care we developed called the Sepsis 6. But the community setting tools recognize that news hasn't fully penetrated and News 2 hasn't fully penetrated. So you can use that language if you're using news, but if you're not, it's just if the patient doesn't look very well or if their physiology is abnormal. And then we ask people to look for signs of an infection. Now, we have a simplified set of red flags without lactate in there for community-based use. But for carers who either don't have training in physiological monitoring or who don't have access to physiological monitoring, we can translate these. And we've done this in other settings to, if you like, a sort of lay interpretation, or better, is an interpretation for people who can't access monitoring. So as an example would be that instead of a blood pressure of less than 90, we put the patient can't stand up unaided. And that has to be a new thing for them because obviously some patients can't anyway. But if they're dizzy on standing, that suggests their blood pressure might be low. If they're breathing very fast, then again, we can translate a lot of this into language. So the key is, if a patient looks unwell, you have to do a bedside assessment. Does their breathing look normal? Are they behaving normally? Or are they confused or dizzy, or can they not stand up when they could do yesterday? Ask them when they last had a pee, for example. A lot of these things, even if you don't have access to monitoring, can be assessed in a slightly different way in the community. Now, for community nursing, this was a niceism here, looking for amber flags. And essentially, the idea was the patient doesn't have a red flag, we're going to look for an amber flag, which was a slightly softer set of criteria, and I'm not going to go into them. And the action points, as you can see on the right there, are get a same-day assessment by a doctor or equivalently trained nurse, work out whether urgent referral to hospital is required, and then agree an ongoing management plan, including scheduled reviews if appropriate. But I think NICE probably recognised that this added a lot of complexity to the tool. And what a lot of organisations have chosen to do is this. It's simply to say that if they don't have a red flag, but you're still really worried, then undertake exactly those same actions. And I would believe that that's appropriate. So the community nursing bundle is very simple, really. It's phone 999. It's ensure that you get a rapid transit of that patient to hospital. We have to recognise that ambulance services are under huge pressure and that disposition times are very long. So if your local procedural policy allows you to, and if it's safe for others to get that patient to hospital quickly, it might well be a lot quicker than an ambulance. And indeed, when we're talking to the public these days, we say go straight to A&E or call 999. Now, in hospital, as I said, we ask people to deliver the Sepsis 6, and I'm going to go through it, and hopefully the reasons will become clear. But then I'm going to describe what we've done with another organisation, Marie Curie, around what their teams can do to help deliver the Sepsis 6 in a community-based setting. So step 1 is get a senior clinician on their way. Step 2 is to give oxygen if somebody's hypoxic. Step 3 is to send a full set of bloods, including blood cultures. Step 4 is to give antibiotics and think about surgery or radiology to drain the source of infection. Step 5 is to give intravenous fluids, and step 6 is ongoing monitoring of the patient. And one of the most important words on any of our tools, which has always been there, is at the bottom left of your screens. It's that word variance. So if a health professional writes in that box, this might be pancreatitis, for example. They might not need antibiotics. I'm waiting for some blood tests to come back. That's sensible medicine. That's antimicrobial stewardship. It's clinical judgment. That should count as compliant with the tool. So here's what we've done with Macmillan, where the ranges of skills aren't quite as broad and the availability, sorry, not Macmillan, Marie Curie, aren't as broad and the equipment available isn't as comprehensive as in acute sector. So there, the language we agreed with them is that they were going to discuss with a GP or on-call clinician. We changed give oxygen to give oxygen if it's available, help the clinician to send some blood tests, give some antibiotics if you can, ensure the patient stays hydrated if you can't give IV fluids, and obviously monitor the patient remains appropriate. Now, across England, we saw some huge improvements when we had a commissioning incentive around sepsis. Antibiotic delivery, for example, in 2016, 1 in 3 patients was getting their antibiotics within an hour, and it is a time-sensitive emergency, so that was a target. By 2019, it was 80%. And it was interesting to note that 3 sequential studies appeared to show that mortality during this time dropped from around 30% to around 20%. Now, we can't claim cause and effect here because the studies were different in the way they examined things, but it's interesting to note, and we saw similar data coming out of New York State. So we get this stuff right, and mortality appears to drop. But there are some barriers. Now, recently, we've done a survey across 6 European countries, and we've asked doctors, and I'm afraid we did only survey doctors. Really, that was down to the cost of trying to survey different professional groups. But we asked whether they thought sepsis was important and whether they thought that sepsis was often diagnosed late. And the vast majority said, yes, sepsis is an emergency, it is serious, but in more than half of cases, they said, well, we miss it, or we delay diagnosis. And then we asked why. And the themes across Europe were the same. Not enough staff, too many cases, insufficient training, and more in France and Spain, lack of familiarity with the steps. You won't be surprised to learn that in the UK, staff shortages was the most reported answer, that's 80%, but the themes are there across all countries. It's not just the NHS that is struggling at the moment. And I think as this piece that we wrote in The Independent cited, that staff shortages are going to cause deaths this winter from sepsis, from any other acute or chronic condition. Colleagues became unsettled when we saw those fantastic process improvements with regard to sepsis. And the former health secretary wrote a stupid tweet around it, which really inflamed our colleagues further. But in this letter to the Lancet, they made 2 accusations. Firstly, sepsis only really affects old and vulnerable people. And hopefully I've refuted that to your satisfaction with those data from New York State earlier. But secondly, it's resulted in a doubling of antibiotic use. Well, has it? We accessed the data table that these authors were referring to, and it's from the Royal Pharmaceutical Society, the RPS. And if you look at the left-hand column there that I've highlighted, it shows that since 2014, antibiotic use in emergency departments has doubled. And that, of course, is alarming. And quite rightly, we should take that very seriously. But then look over to the right. This is total hospital use of antibiotics, which the authors chose not to declare. It barely changed. An increase of 1% is worse than a 0% or a drop, of course, but it's by no means a doubling. So what these data actually showed, to my mind, is that incentivizing better sepsis care in the acute sector meant that we gave antibiotics earlier in the patient's journey, probably saving lives without the adverse consequence of increasing total antibiotic use. But the academic organisations have listened, and this is one, the Surviving Sepsis campaign, which is a multinational academic guidelines right. And they changed their approach with antibiotics in October of last year. They said that if a patient's got shock and you're pretty sure it's sepsis, or if you're just pretty sure it's sepsis without shock, you're going to stick with 1 hour. But if the patient does not have shock, and your diagnosis is a little bit in doubt, which is quite a number of patients, it's not always obvious that someone has sepsis, then allow a broader window of 3 hours. And in the UK, our own Academy of Medical Royal Colleges is acting similarly. And it's not using shock as the discriminator, but this new proposal from the Academy, which is being re-evaluated by NICE as we speak, looks at very much the same thing. That if the News 2 score is 7 or above, you've got 1 hour to give your antibiotic. But if it's 5 or 6, we're going to allow a broader window of 3 hours. And you can see there's a few criteria that can bump the patient up a level. So if a patient's got a low News 2 score, maybe it's 4 or 3, but you're really worried about the patient, or they've had recent chemotherapy, for example, you can bump them up and treat them as an amber flag, and similarly bump an amber flag patient up to a red flag. And with the GP tool, we ask them to start a GP bundle, which is much the same as a community nurses bundle, essentially get that patient to hospital. And if they have an amber flag, so a lower news 2 score, then we allow them to make a decision as to whether it's safe to keep this patient in the community and perhaps schedule a review. Now, there are resources available because you're not going to retain all of this in 25 or so minutes. So as you can see there, we have e-learning, including a care worker's guide, as well as e-learning intended for those working in the acute setting. So those are available to access on our website at sepsistrust.org. We've got manuals, so we've got PDF and physical manuals, books for those who prefer to read a physical book like I do, that help to guide people through the process and what to recognise. Now, I'm just going to finish now with describing this. Now, ignore the grandiose statement on that. That works better when I'm on a stage talking to a very diverse professional group. But really what we have to consider is that sepsis is not separate from antimicrobial resistance. It's not separate from infection prevention. They are all part of the same problem. They are all dealing with stopping people dying of infection. So we launched this in February, the Infection Management Coalition, and it is funded by industry, but it also involves industry regulators, as well as charities and professional societies. And really what this is doing, and this has gained huge traction in the WHO and within Westminster, is we're calling on governments to stop looking separately at infection prevention. Vaccination, clean water, sanitation, hygiene can prevent some infections, of course, but they can't prevent every infection. So we're calling for governments to stop looking separately at infection prevention and sepsis and antimicrobial resistance and consider them all together within one holistic policy. I think this is gaining enough traction that we can start to become confident that this is going to influence policy. And that will mean that it will influence the way within this country healthcare is commissioned from the perspective of infection. So thank you for listening. We only had half an hour. It's a lot to get through, I recognise that. But really, this is the quantum we're talking about. Getting this right across our communities is going to save thousands of lives every year, and that's got to be worth trying for. Thank you very much.
Thank you very much, Dr. Daniels, for that very informative presentation, and most definitely for highlighting sepsis can affect anyone. It is an absolute emergency, and it should be taken quite seriously. It does require that early recognition and prompt action to reduce mortality. So thank you so much for relaying those key messages to us. I'm going to now hand you over to Caroline Coster, so she can share her very inspirational story with us.
Thank you, and thank you, Ron, for all the work you're doing. My story starts, well, it starts a long time ago. I'm 60 now, but if you look back 3 years, this was me. So I was a teacher at a big school in Henlow. I was head of computing and did a lot of other activities as well. Can we have next slide, please? I was a mum. I have 2 daughters, both of whom now work in the NHS. My elder daughter is a nearly qualified GP, and my younger one is a social prescriber. Next slide, please. I was a crafter. I made things out of old jeans, sold them to raise money for charity, and all the money went out to help a village in Kenya. And I set up businesses for women so that they could feed their children without having to turn to prostitution. I loved walking. This is our first dog, Duke. We've just added a second dog, Daisy, and this is at the end of a very interesting scramble in the Lake District. And then in March 2020, I developed COVID. And although I, after 2 weeks, felt as though I'd started to recover, I didn't continue recovering. And over the course of a week, I was seen by, I think, 6 or 8 medical professionals. And there's no blame attached here, but I, looking back, can see I was developing sepsis over that week, and it was not picked up. I was correctly screened. They recorded all those screenings in my notes, which I've seen, but I just didn't have enough of the clear signals to indicate that I had sepsis. So my point here is, it's that feeling of, I wish I'd known and I wish I'd asked, could it be sepsis? Because mine was missed, and I ended up in hospital on the Friday with severe sepsis, and then was taken into critical care on the Saturday and immediately put on a ventilator. Thank you. Next slide. And I ended up in a coma for a fortnight. All my organs failed. And when I woke up, my hands and feet were black. I was in critical care for a total of a month, and it was there that they told me that my hands and feet would have to be amputated. I actually got the second photo taken because I found it bizarrely amusing that they were marking both my arms. I know it's something they have to do for operations, but I just found it quite funny because to me it was pretty obvious. Thank you. Next slide. The care I received at Bedford was outstanding, and I was very rapidly recognised as someone who was very determined. I was constantly pushing myself to do more. But of course, this was in the time of COVID, and what made my experience particularly difficult, I think, was that I could virtually have no visitors. The hospital were great and allowed me to have visitors in the garden, and here you can see me meeting with Duke after my sets of amputations. And in fact, those photos are taken after my first wrist amputations. I later had to have revisions of my wrists because they got infected. Thank you. Next slide. So I worked really hard at learning new skills. It was terrifying because when I came out from coma, I could do nothing. I couldn't move myself in bed. I couldn't sit up, but I did all the exercises they gave me and constantly pushed myself to do more. The OTs were brilliant and developed this arm splint for me so I could start feeding myself and using my computer with a stylus that one of the nurses brought in. Thank you. I signed my name for my second set of amputations of my wrists, something of which I was quite proud. And I started my blog, which has carried on for this day, and got loads and loads of support through that. Thank you. I tried to amuse nurses, so you can see I got them to face paint smiley faces on my stumps, and I would hold those up to people as they came into my room to cheer them up. And actually it was nice because a lot of the staff said they loved coming into my room because I was always quite positive, and it cheered them up. I got to go home for an afternoon, which was a really good transition between the hospital and going on to rehab at Roehampton. I was very fortunate to get an inpatient place at Queen Mary Hospital in the Douglas Bader unit. Thank you. And there I had casts taken of my legs and my arms. Carry on through the slides, please. And I learned to balance in the gym. And I worked really hard in the gym. I've never been one who loved exercise for its own sake, but I learned to love it in the gym, and I could see how much good it was doing me. Thank you. It's amazing the amount of effort that has to go in to learning to stand on prosthetic legs. This is me standing for the first time after my amputations. And what I've learned is it's a bit like walking on stilts, but instead of your feet being held carefully in place, they're actually in buckets, and you have to really develop those stomach muscles. I was doing 120 sit-ups every day, so I had enough stomach power to hold myself up, and I did an awful lot of work on balance as well. Thank you. Next one. I learned to walk because I couldn't easily use the rails that they would normally have used. They had this walker for me, which was called a pulpit, which I thought was quite amusing, instead of a Zimmer frame. And initially I learned to walk with two people standing with me, one in front, one behind. Then I learned to walk with only one person. Then eventually I was allowed to walk with someone just watching me instead of right beside me. Then I was allowed to walk with the pulpit on my own. Then we changed the pulpit to 2 sticks, and I progressed again, 2 people, 1 person closely watched, and then to 1 stick. And then the time came, next slide please, when I was able to walk without sticks. I participated in a lot of the other activities like gardening. which I loved outside, and I conquered stairs right at the end, although I have to say stairs are still something of my nemesis. Thank you. I learnt to use a variety of prosthetic arms. One of the things I try to get across to people is that losing your hands is obviously much harder than losing your feet. And there is a tool that replaces your legs. Prosthetic legs do more or less the same job as your legs would do. There is no one tool that replaces your hands. And I have about 9 different hands now. The ones you can see here are my wash hands, and you can put a sponge in one of them, and in the other, I've got permanently attached a head scrubber. With them, I can get washed and dressed on my own every morning. Next one, please. Then I have my hooks. These were developed for soldiers returning from World War I. The design has basically stayed the same. These are probably the most functional of the tools, but I think they're probably also the ones that certainly I find hardest to accept, and other people in the street definitely find hardest to accept, because they look quite alien. Next one, please. But with my hooks, I've learned to do a huge range of things. I did learn to eat with them, although I now have another tool I use for that. But they're also really good for other crafts that I do that you'll see later on. Thank you. Next. This is my koala arm, and with this I can eat. It's a passive attachment, so you can't move the things in it, but it's brilliant for eating and much less obvious than any of the other arms. Thank you. Next one. And I actually ate outside for the first time with that. This is my bionic arm, and at the moment this isn't working for me. It's the least functional of all of my devices, and it's actually the hardest to use, but it's also the most acceptable externally. People think it looks really cool. There's a general belief that, oh, you've got a bionic arm now, you'll be fine. And that really isn't the case. It's another tool in my arsenal. And a lot of the time, my stumps are the best thing. Thank you. Next slide. Now I'm having loads of new experiences. This is when I went back into school to see my pupils again after I got home. And I was filmed by the BBC for that, which was quite an experience. And they followed me on various activities. I've always said I will do any appearance as long as it's not sensationalized. It can't be a pity me story, and it has to mention sepsis. And I like to think I've managed to raise quite a lot of awareness that way. Thank you. Next one. Oh, I think that's gone past, but that was a brief shot of me meeting the Lord Lieutenant of Leicestershire, of Bedfordshire, and talking at one of her services, and a cat that I've named at the Bedford Cat Cafe, who's called Utangi, and he's only got 3 legs. Next one, please. I go across London on my own in my wheelchair and think nothing of it, although the people often do, but it's actually, if you plan your journey, relatively accessible. Thank you. Next one. I've been horse riding. I've been up in a gyrocopter. Getting in and on and off the horse is interesting, but I love both of those. Next one, please. I've been swimming. Didn't love that quite as much. It's quite terrifying if I go onto my front because I can't actually get up again. And I now have my own bike. I have a tricycle, and I absolutely love riding that. And it gives me a sense of freedom. Next one, please. I received an MBE and the Order of St Alban for my services to education and to charity fundraising, and that was a really fantastic experience. Thank you. I've been a model for a lovely clothing company called Popsy, who make these beautiful dresses that I love, and that has been amazing. Who would have thought ever that I would turn out to be a model? Certainly wasn't on my list. Next one. I now weave. I don't sew anymore because I can't do it as well as I used to, but I've taken up weaving and love it. And it gives me a way of expressing my creativity. I'm hoping to make scarves to give to all the people who've helped me, but it's a slow process at the moment. This is the school in Utangi, which my fundraising has helped to build. With all the denim items I sold, I raised about £40,000. That wasn't enough to build the school, but it was a start. And with a group of friends, we've built this school. It's called the Rainbow Unit. It's in the little village of Utangi near Kenya, and it's going to educate up to 130 children with disabilities. And it's educating them in a trade so they can actually support themselves. It's very exciting because there's a huge stigma to disability in Kenya. And this almost felt like I'd come full circle when this was built. I go out, I've learned ways of taking photographs. I'm so lucky that this happened to me now because technology makes so much easier. So for example, I can take photos with my voice on my phone, and I would have missed it if I couldn't still take photographs. Next one. I've had myself and my dog Duke registered to be Pets as Therapy volunteers. And we go into schools and children read to him. I've had to stop while COVID rates have been high, but I'm looking forward to getting back again after Christmas. And excitingly after Christmas, I'm hoping that I'm also going to be going back into Bedford Hospital, maybe to visit patients with Duke, but definitely to support the nurses in critical care by providing Duke as a petting dog so they can de-stress. And again, that's another example of how things have gone full circle for me. And importantly, I can eat ice creams. I like to think that I can do most things that I want to. Sometimes it's a balance between how much energy it takes and how much I want to do it. But I'm very good now at finding ways around things. Next one, please. We've just had our kitchen redone, and now I can actually do the washing. It has given me a huge boost to my independence having the kitchen redone. So the washing machine has been raised, simple solution that made a massive difference. Next one, please. Oh, there's the video of it. It's amazing how much difference it makes to be able to do normal things again. I like to say that this is my second life. My first life was good, and my second life is good too. It's different, but it's still good, and I can still do the things that I want to do. I don't need anyone's pity. I might need support in finding new ways of doing things, but there are always those ways of doing it. As you can see, getting the pads out, the wash tablets out, takes me a little longer than it used to. But it's still possible to do it. It just needs doing in a slightly different way. I'm very lucky as well that I have very pointy elbows, and that means that I can use those to press buttons and so on. And actually, I quite often type with my elbows rather than with my the ends of my stumps or with a stylus. Should be able to go on to the next slide now. And you might want to press play to make this go, but I can also cut vegetables up now. So for 2 years, I wasn't able to help with the cooking at all. And while I'm still not safe with heat, I can now prepare vegetables. And again, that gives me a huge sense of self-worth. Thank you. Next slide. And we've just got a new dog. This is Daisy. She's 6 months old, and we're hoping to train her to be my assistance dog to help me with the things that are still very difficult, like, for example, pulling knickers down and up. That's really difficult with no thumbs, so I'm hoping Daisy can be trained to do that for me. Thank you. That's really it. Those are my links online if you want to find out more, and I'm very happy to answer any question. And I think I've managed to stay just under the half an hour.
Thank you so much, Caroline. Thank you so much for sharing your experience and your story. I mean, I can only say that you're an absolute inspiration. I really admire your determination and your constant positivity throughout, despite what you were going through and all the life changes you had to make. So yeah, absolute incredible inspiration. Thank you. And I guess one thing I've taken away as well is that asking that question, could it be sepsis? If anyone, I'm hoping that, we've taken away key messages from today, but I'm really hoping that we all are now sepsis savvy as a result of today's session, and that we will be able to spot the signs of sepsis in order to obviously save lives. Dr. Daniels, did you want to add anything?
I just wanted to say, and Caroline, thank you so much. Incredibly brave, sharing such intimacies into your personal life, really. I think that's incredible. And obviously you've been on an incredible journey. I just wanted to make the point, and I hope you don't mind, Caroline, that for every person who has a very visible disability after sepsis like yours, there are 10 or 15 people who have invisible disabilities, which can be equally disabling, and they'll range from cognitive through psychological through physical. And I just sort of want to wave a flag for those people. About 40% of people who survive sepsis have life-changing after effects that they still experience 1 year after their sepsis. So this is not just about the people who've suffered limb loss.
Yeah, and it's the same for me, as well as the obvious signs, I still do have cognitive dysfunction. I often have times when I can't find the right words. I get exhausted incredibly easily. If I go out for the day, I'm knocked out for 3 days afterwards. And pacing is so important. So yes, Ron, I agree. We need to be aware that sepsis, it's just like long COVID. It's just not had the attention of long COVID. It really is. It's completely disabling.
Thank you.
Okay, I'm just going to go to Jessica to ask if we have any questions. I don't think I've seen any in the chat.
No, we don't at the moment, Tanya, but people can submit questions to us at a later point. That being said, we're having lots of compliments for Caroline and your story, so thank you very much, Caroline. But yes, so I don't think we've got any questions at the moment, but as I said, people are more than welcome to submit questions at a later point if they want to email us or give us a ring, and we will of course endeavour to come back to people.
Okay, all right then. Well, a massive thank you to both Caroline and Dr. Daniels for presenting today. And I guess, yeah, that's it. Have a lovely Christmas, everybody.
You're very welcome, and the same to you. And if people want to contact me